Thank you for joining us. This is Midwifery After Dobbs, a collaborative event between the Graduate School for Education and Human Development and our friends at the School of Nursing here at the George Washington University, which is located in our nation's capital, Washington, D.C. We want to thank you for joining us today and welcoming you. We want to acknowledge that March is Women's History Month. And thank you for all the contributions that you have made towards the celebration of Women's History Month here at GW and in the DMV area. I'd like to start today with a land acknowledgement, and I'll put it in the chat so everyone can see it. And you may know from my practice that I have some issues with non-performative land acknowledgements, but I do think it's important to start this event with a land acknowledgement for two reasons. One, we know that many of the practices of midwifery do come from indigenous practices, right? And they come down from, not necessarily organized Western medicine, but from the indigenous folks that we may have here within the area or anywhere around the world. And as this is Women's History Month, we know that there's a disproportionate amount of the negative effects of patriarchy and white supremacy that fall on Native women. Native women are much more likely to suffer from alcoholism and much more likely to be the victims of sexual assault. So I do believe it's important to start this event with that sort of land acknowledgement. With that said, this is a Women's History Month, and we at GSEHD are delighted that the folks from the School of Nursing have decided to come over and share their knowledge and wisdom with us here today. So we will get to that in just a moment, but I would be remiss if I didn't say one word about what Women's History Month means to us here at GW. We are, very proud here specifically at GSEHD to be a female-led institution. Quite frankly, the majority of our deans, the vast majority of our department chairs are all women. Our staff that work extremely hard and without GSEHD would not be what it is today are majority women, and our students who are working as educators and counselors and organizational leaders towards the future are also women as well. This is not to acknowledge that as far as we have come, there is still a lot to go. There are still areas of this country, which claims to be the richest country in the world, where a woman will make 75 cents to the dollar for a man. There are still areas of this country that despite doing the same work with the same credentials, women will be hired at a lesser rate than a man. And as we have moved in to the sort of teeth of the 21st century, we are now fighting for, once again, a woman's right to control their own bodies. And because of those sort of ways that we need to move forward, we decided to host an event here today focusing not just on the practice of midwifery, but how that practice has been modified by recent public policy and Supreme Court decisions and how it may affect women's rights. So let's do two things here today. Let's both celebrate how far we have come, and let's all acknowledge how far we need to go. So two cheers for GW for hosting a Women's History Month event. But as we cheer, please know that we must continue fighting. And what we have for you today, what we have for you today, this afternoon, quite frankly, are two sort of people right on the front lines of those fights. And I would like to introduce them here at this time. We will first go to the professor, then we'll go to the student. And after the introductions, I'll tell you how this will work. Dr. Tarnisha Hemphill is an assistant professor of nursing at the George Washington University. She received her doctorate of nursing practice and nursing education from Regis College. Prior to joining the faculty at the George Washington University, she was an adjunct assistant professor at Georgetown. She taught at the Women's Health Nurse Practitioners and Certified Nurse Midwifery graduate students there. She worked full-time as a full-scope certified nurse midwife in Baltimore City, where she provided healthcare for those from adolescence to menopause. Her area of expertise is promoting diversity and equity in healthcare and improving prenatal access to underserved populations and health disparities. Please welcome our friend, Dr. Tarnisha Hemphill. The next speaker will be the future Dr. Michelle Clausen. As a certified nurse midwife herself, Michelle provides comprehensive medical, gynecological, and reproductive care to those in the DMV area. Michelle is active in health policy and is a member of the DC Board of Nursing Committee and is a current legislative representative, I don't know where you find all the time for this, Michelle, to the DC affiliate of the American College of Nurse-Midwives. Michelle is a three-time GW graduate already, completing her undergraduate studies in public health at the George Washington University in 2009. She then graduated from GW's Accelerated Nursing Program in 2013, and then received her MSN with a concentration in nurse midwifery in 2015. She is currently completing her third year at the GW School of Nursing's Ph.D. program and will soon be a doctor. And her current research is focused on understanding how maternal factors such as spiritual well-being and early childhood advocacy influence bonding in the prenatal period. So, my friends, we're about to have a conversation. This will go on for maybe about 45 minutes. As I said before, please feel free at any time to put your questions in the chat, and we'll get to that at the end of the period that I have a discussion with our wonderful guest. Please note that this conversation today here, while on an academic topic, does broach a topic, a woman's right to choose, abortion rights, which cause strong feelings on either side. We are not here to take a position on the right to abortion in any way. And in fact, any information that you hear today is solely the information provided by the guest or the facilitator, and does not represent any committed view by GW, the Graduate School of Education, or the School of Nursing. We are here to have a conversation, and we screen no one away from that conversation. However, we will ask that that conversation is had in a civil and a collegial way. If you intend to disrupt the conversation in any way, as a private school, we do reserve the right to remove you, but we hope that doesn't happen. Or as I always say, as my mother would remind me in my teenage years, you understand, you don't have to follow the rules there, but you do if you want to stay, all right? With that said, why don't we go ahead with the first question, Dr. Hemphill, Michelle, and I just want to get to know you because I read your bio, I've learned a little bit through your CVs. It's remarkable. It's really a remarkable body of work. Why don't you tell the audience, whether they are attending here right now or will view this on the video, who you are, how you got about the work that you do, and a little bit about both of your emerging research agendas. We'll start with Dr. Hemphill, and then Michelle, we'll go to you.
Okay, that was such a wonderful introduction. Thank you. Hello, everyone. My name is Dr. Tarnisha Hemphill. I am a certified nurse midwife, and I am an assistant professor, like he said, at George Washington University. I currently live in Maryland here, which is raining and a little gloomy. I got into nursing because I was that kid that had a stethoscope and was listening to their family's heart rate. I was that kid that took care of all of her dolls. They were always very, very healthy on my watch. And I just always wanted to take care of someone. So it just seemed like the natural choice to get into nursing. I chose to get into midwifery because I was working as a labor and delivery nurse and had a real good bond with my patient. I was helping her throughout her labor and then throughout the pushing phase. And my shift was ending. I worked a night shift and my shift is ending, but I told her I'm gonna stay until the baby is born. And she thought that was amazing. The doctor overheard me and said, "Do you want to assist with the delivery?" And, I didn't even know how to respond to that. And the patient thought it was great. And before I know it, the staff had me in a gown and gloves, and I'm standing there. Now, in all honesty, I did nothing. But in my mind, I did everything that has always stayed with me. And here I am now, 16, almost 17 years as a nurse midwife. I joined George Washington University because they have a midwifery program that they are now switching and becoming to an online program, which I think is awesome because we can capture more people and it is so needed. We are in the pre-accreditation process and we're feeling really, really confident that we will get approved for that. And we're hoping to get started in the fall. So I am just so excited to be a part of that whole process. And then I think your other question was about research. So my future research goals is to focus on mentoring. I'm really interested in mentoring BIPOC students, just like kind of writing about that and researching that, specifically on them going from an associate's degree to an accelerated program and just the support needed for that. And then also my passion is on prenatal attendance, prenatal care attendance. So not just the access, but keeping them coming to their appointments. And it's really difficult for some patients. So that's kind of my goals.
No, thank you. Wonderful. And it's wonderful how, people have dreams when they're younger and they're able to fulfill those dreams. I think, Dr. Hemphill, you are a legend in that respect, and we appreciate you here at GW. Michelle, we're going to have to top that.
No, not even close, but that's okay. My name's Michelle Clausen, and I'm a certified nurse midwife. I have been for 8 years now. And I guess right now they call me the GW lifer because I got here when I was 17 and haven't left since. But GW has been very good. I started my career in public health, and I was always an EMT, so I always had my hands kind of in the medical field in some way, but have always been holistic in nature and have always sought for my own care a much broader perspective on health. And I don't have a fun story about midwifery on how I was drawn to it, but I do feel midwifery found me. And it honestly, I was an only child. I was raised by women, older women who had no idea of what a midwife was and why someone would want one. And it just so happened when I decided I wanted to be a midwife one day, GW had opened up their nursing program. So I went back to school, became a nurse with the goal of becoming a midwife. And then as soon as I graduated from nursing school, GW had just opened their midwifery program that was in conjunction with Shenandoah. And I continued right on and then worked at GW as a nurse midwife and have been since. And over the last 3 years, I have been a Ph.D. student now at the School of Nursing, where I'm hoping and I have been developing the skills that I could represent midwifery in a different way. We need more higher level midwives at the seat, at the table of change, and being able to have these high level discussions, being able to bring the evidence of what we do to the table and just to be heard. There is a consistent and historical misunderstanding of what a midwife is. And it continues on to this day. And my work at the Board of Nursing and with local legislation, it just goes to show continuous misunderstanding of what we do and why we do it. So my efforts in my program have been geared to develop all the skills, learn everything I can, so I can have the capacity to be able to fight the good fights that, that the midwives who are in the trenches are getting tired.
No, and I hear that. And thank you not only for your persistence through GW. I think, there are a lot of stories you have, but for joining us here today. And thank you both for sharing your wisdom. I do want to get to a sort of definition of midwifery and what it is, right? I think Michelle sort of led us there. But before we get there, one of the best parts of my job is to be able to have events at these affinity groups and talk about not just the subject of the event, but why we're having the event as well. And I just want to take a pause here and acknowledge that this is Women's History Month. I want to ask both of you, and we're going to try to do this with as few tears as possible. Don't choke up, but could you identify at least one female role model in your life that had an impact and helped you be the awesome woman that you are here today? I start with my mother, who was the daughter of a nurse's aide and eventually became a registered nurse herself, who I'm not going to cry. We're going to stop there because I tend to get emotional, but my mother. We tend to often have people at work. And I can see people right here on the call right now, Teron Waters and Dean Sharon Daniels and Chris Dietrich and Lottie Lent and other people here at GSEHD that inspire me every day. They give more than they should. They get compensated less than they can and give back to try to make the world a better place. So don't be me. But if you could identify just one person that is a woman in your life that helped you be who you are today before we get down to business, I'd appreciate that.
Who wants to go first? You want to go first, Tarnisha?
Oh, sure. And so I am sharing the exact same answer as Mr. Wright here, and I'm going to say my mother. You know, I was really thinking, I didn't want to be cliche and everybody's going to say that, but I mean, that's the answer for me. It's my mother. And she's started me at a young age of understanding creating attainable goals, not just any kind of goals, but attainable goals. She showed me the work it takes to achieve set goals and that it is not easy and it is not quick. And then just the feeling that you have once you've reached your goals. So just learning that early on and just being persistent in that and her encouragement for me throughout that I feel like has taken me very far. So that would be my answer, would be my mom.
Michelle?
I mean, it's absolutely my mother, but I'd add also my grandmother. I was raised by both of them. They are both no longer with us here in the physical world. But, you know, it's not lost on me that the person who brought us into the world is the person that has the most profound effect. And as midwives, right, we're honoring that today. But both my grandma and mother never, you know, they never had the opportunity to go to college. It was beyond their wildest dreams that, you know, I would be able to do that. And, you know, I mean, coming from that, I'm consistently humbled on how grateful I am at where I'm at. And I think they always taught me to stay humble and give back. And a life of service is something that was honorable to them.
No, that is beautiful. That is beautiful. And behind Dr. Hemphill, we have the word blessed. And I feel like we all are blessed to have such wonderful women in our lives. All right, with that detour done, let's get back to business. And Michelle, I am going to start with you for this answer. So if Dr. Hemphill needs to play cleanup, she can. But first, let me apologize, right? As a cisgender male, this is an area of which I know nothing about, right? And, you know, it is literally the privilege of ignorance, right? That, you know, I will not be responsible in my family for bringing in a life. So I know nothing about midwifery. I apologize in advance. So why don't, Michelle, you start us off, and Dr. Hemphill, just give us a layman's term definition. If you were talking to a freshman in high school, what is midwifery? How do we distinguish it from other practices? You know, how can we define it? Just, you know, start us off rather basic.
I think that's pretty complicated, but the word midwife traditionally means with woman, and it's ancient. It's been around as long as people have been having babies. And traditionally, it was the woman who sat next to the other birthing woman and held space and navigated the journey throughout pregnancy and birth and throughout all the life cycles. And the midwife traditionally was a respected person of the community who, you know, birthing partners, birthing people would go to for advice and counsel and wisdom. And today, midwifery in the United States, there's a few different ways to look at it, but it is a healthcare provider that provides care to women and birthing people throughout the whole life cycle, not just pregnancy in the perinatal period, not just postpartum, extends to menopause and beyond, and it starts in the early reproductive years. The definition of midwifery in our scope of practice has expanded to really include the terms anyone who seeks midwifery care should have a midwife. And depending on where you are geographically in the US, a midwife may do a lot more primary care type of work versus reproductive work. And then I don't want to go too far and complicated, but in terms of licensed midwives, there are 3 types of licensed midwives in the US. Certified nurse midwife, there is something called a certified midwife, and then there's something called a certified professional midwife. And then we have our lay midwives who are not licensed, but in the United States hold a huge place in a lot of communities, particularly in Indigenous communities. So when someone says midwife, it's always interesting because it could mean a lot of different things. It could mean a lot of different types of midwives, and it might mean that they work in different settings. And happy to go into that, but that can also get kind of complicated.
No, that's a wonderful place to start. It's a good place to remind our audience that if you have any questions, please feel free to put them in the chat. At the end of this colloquy I have with our special guest, we'll have an audience Q&A, and I've got, about 1 million follow-ups. But Dr. Hemphill, do you have anything to add to Michelle's definition? What is a midwife and what is midwifery?
Well, I think it's a great question because I remember being in midwifery school and I had an assignment where I had to come up with a couple of short sentences for what is a midwife, what is midwifery? And I'm thinking, they said that if you're in the elevator and someone asks you that, and I'm like, no one's going to ask me that. And people who come see me are going to know what a midwife is. And so as I started practicing, I realized that my thought process on that is completely incorrect. I was surprised. For example, I would introduce myself and say, I'm a midwife. And they would say, oh, I'm not having any baby in some backwoods area somewhere. And I'm like, oh. Or I would have someone in their 60s or 70s when I introduce myself and say, oh, my baby days are over. I'm not having a baby. So I always have to say, well, let me tell you a little bit about what a midwife does. Let me tell you a little bit about the care I provide. And so I am finding myself having to always kind of educate and inform people about what a midwife does. So everything that Michelle said, also that we believe in medicated and unmedicated births. We birth babies in the hospital and home or a birth center. We are known for low risk and low intervention, but we can also work in tandem with the MD and assist with high risk care if needed. And we really believe in collaborative care. It's just an expansion of different things that we can do. And we are being asked that question either directly or, inadvertently being asked that question and having to kind of educate the world about how the fantastic world of midwifery.
No, that's wonderful. And that leads right in neatly to the next question I have. And Dr. Hemphill, I'll spare Michelle and I'll have you actually start us off here. And that is, can you tell us a little bit about the similarities, differences, relationship between midwifery and obstetrics and gynecology, right?
Okay.
If you look at the sort of public culture, right? There seems to be a lot of tension there. Many people know nothing about midwifery than what was exposed on the Mindy Kaling show, right? And
yes.
to be, and of course that was exaggerated for the purposes of a sitcom. But if you actually study the history and the Black history and the Black female history of midwifery, midwifery was the dominant way that many people gave birth. Particularly the dominant way that many of the ex-slaves post-emancipation gave birth, until the dominance of medicine came, and quite frankly, if I can say it this way, white male doctors sort of recaptured the practice, right? So, that is the historical sort of aspect of it. What's the practice aspect of it? As someone that practices this, teaches this, and does research on the pedagogy of this, what's the relationship between OBGYNs and midwifery? Is it better than we might expect? A little bit more tense than what's the truth?
What's the truth? So similarities, we are both skilled and highly educated in women's health. This is our thing. We both have to sit for a board and be certified in something, sit for an exam. We have to go through a program of some sort. So we have the education, we have the skills, both didactic and clinical. That is our similarity. Differences is that the docs would perform more of the surgeries. However, midwives can be trained to be first assist and assist MDs with a C-section or maybe a tubal ligation. Once again, docs are known to take care of more of high risk, but like I said earlier, we can work with MDs and work in a collaborative management to assist with high risk. So there are some similarities and some differences. As far as tension, just as far as me in practice, unfortunately, there is tension. And I've noticed tension when there is an MD that is ill-informed about the different services that midwives can perform. They are ill-informed about the scope of midwifery, right? And so then they put restrictions up and barriers up and kind of tying our hands as to what we can do and the different things that we can offer. And so then there will be resistance there of us having to not just explain to our patients about what we can do, but explaining to the providers that we're working with. And so when they're constantly kind of tying our hands and restricting us and just not educated and not taking the time to learn about the benefits of midwifery care, that is very frustrating. I try to teach all of my students that when you're looking for a job, you want to, not only are you being interviewed, but you're also interviewing that practice and you're interviewing them. And you want to find out if that doctor is midwifery friendly, is what I like to say. Do they get us? Do they understand us? Have they worked with midwives before? Because if not, it's going to be very difficult to make a place for yourself and for you to really keep having to reinforce to them that I can do this and I can do things independently. So that is the conflict that I often see. It's great when I find a doc that is midwife friendly.
Yes, yes. And Michelle, I'm going to ask you to support that or contest that if you wish, but I also want to acknowledge a question that came up in the chat. That's a great question to answer at this point. What's the difference between midwives and doulas? Because I think, it's on one spectrum, it's the OB/GYN question, but then the doula question as well. So Michelle, anything to add? And do you want to speak to that very good question?
I think all of that it's definitely our truth that we carry. I would say it's an evolving relationship that I think midwives have with physicians, and it's very dependent on where you're at, the historical context of how obstetrics is practiced, what setting, the geographical location. I think inherently midwives are trained in a different philosophy of care. We are comfortable with judicious use of intervention. We are comfortable with shared decision-making. And that is where we live, in this world of shared decision-making. And we're comfortable with putting the client, the patient, in a seat of power where we can sit, as we midwives often say, we sit on our hands and wait and see. And I think that is where midwifery stems from, listening and watching before we react. I think in the medical structure of education, it's intervention heavy, interesting power dynamics, other pressures that, because of the training and the environment that physicians tend to be bred in, can create a lot of conflicts and confusion when you then practice in such an intimate area such as gynecology and obstetrics. So I think that's the one thing that I would add. In terms of midwives and doulas, doulas are non-medical professionals who work side by side with midwives. They tend to, so they're non-medical, and they support the client throughout their pregnancy, but specifically throughout labor in terms of comfort measures, Oftentimes they will be at home while the patient is laboring until they're ready to come into the hospital. If the person's birthing at the hospital, if it's a home birth, they, will be supporting the client. Labors can take a few days, they can take a few hours. So they're providing a lot of the non-medical support that is required of a labor. And there's a lot of evidence on the efficacy of doulas in terms of having a doula with your birth. You tend to have better satisfaction of your birth. Less pain intervention during labor because you have this constant support system. And just overall limited interventions usually when you have that doula support. So midwives strongly encourage the use of doulas. It's not a replacement. They're support to the whole family unit on this journey. And a lot of states are working on trying to figure out how can insurance reimburse for this expense that's often out of pocket.
No, that's a really good response. Dr. Hemphill, anything to add on the midwife doula distinction?
The only thing I would add is that just make sure I'm not muted, that they're also now trying to use midwives for postpartum care as well, which I think is amazing and definitely needed. And they have shown that helps to reduce postpartum depression. So I'm always encouraging patients to please, get that relationship with the doula and continue that relationship with that doula. So I think it's a great service, and I definitely like to see more of that and us working together more.
Fair enough, fair enough. Michelle, this question goes to you to start. When we started the event, you listed off several credentials, right? A certified nurse midwife, a certified professional nurse midwife. Could you talk just a little bit more about that? And as a consumer, right, there may be some folks in my school that are like, I appreciate the education of it, but I'm planning to be pregnant in 9 months and I want to know if I should get a midwife, right? Should they be looking for people with that certification? Does it matter? And I don't want to, if you can answer this in the most academic, non-self-interested way as possible, I'd appreciate it.
I think it all depends what you're looking for. So like I said, in terms of licensure, there are 3 in the US. This is different internationally, but there are 3 types of licensed midwives. You have, and I'm going to group one together. So the certified nurse midwife and the certified midwife CNM/CM. Those are your midwives that are primarily going to be in the hospital-based setting. Your certified nurse midwives, just as the title explains, they were nurses previously. They may or may not have practiced. They have a master's degree and they sit for boards. The CMs similarly have to get their master's, sit for our same board, but they're not nurses. Again, the CMs are not quite, there's not many of them in the US and not all states. There's only a few states actually, I think right now that utilize CMs. But the majority of midwives who are in the hospital are going to be certified nurse midwives. And they are, like I said, they're advanced practice. They're considered advanced practice nurses. They have license. They can prescribe medications, all those things, depending on the states. They, like DC, Maryland, have independent authority or independent scope of practice, which means we do not need physician oversight or anything like that. So that's really important. Your CPMs, your certified professional midwives, are midwives that are mostly in birth centers and home births. So for someone, and that's their expertise. Their expertise is in the home birth setting. And so for someone looking for a home birth experience, and they're, especially in this area, in the DMV, we're really lucky. We have a lot of options for home birth, hospital birth, and some birth center birth. So it really depends on what kind of experience the person who's pregnant wants. But CPMs are, again, experts in home birth. And we we work, there are practices, home birth practices in the area that have both a CNM and a CPM. And, it's a great shared knowledge of skills.
No, thank you for that. That makes sense. And hopefully that both educated the audience here and will educate the public to their choices. Dr. Hemphill, anything to add to Michelle's response?
Oh, no, nothing in addition.
No.
I guess we also forgot, about lay midwives. And that's really important. I think it is, because sometimes people think the more acronyms that we have, the better we're going to be. And I think sometimes there's fault in that thinking. When we're so focused on licensure, we're so focused on this structure, we're forgetting about where we've gotten our roots from. And the indigenous midwives in the United States have recently it's been highlighted, particularly in Hawaii. Hawaii is trying to pass legislation that says if you're a midwife, you have to be licensed. And in Hawaii, for example, there are very remote areas, indigenous populations in these remote areas who are birthing, and they rely heavily on the indigenous midwives, lay midwives who are unlicensed, but have been, midwives forever, generational, learning from, they've been learning for way longer than I have, and of course have no credentials, but are well respected and trusted in the community. And now there's new legislation to say, hey, if you want to be considered a midwife, you have to be licensed. And so really interesting debate going on right now about, what is a midwife and what does that mean? And if we're protecting the health of the community, I think we have to be careful about putting restrictions on members of the community who are revered and honored and trusted and who are birthing babies.
No, I hear that. And thank you for the addition to that. I think that in our country, we're dealing with a reckoning right now of a lot of jobs that we've put behind the college degree wall that may not necessarily have needed to be there. So thank you for adding that, Michelle. So now I do want to turn down to sort of the topic of the hour, and that's sort of how the decision in Dobbs versus Jackson Health Organization. And for those that may not know, Roe v. Wade, way back in the 70s, said that there was a qualified right to an abortion nationwide in this country. That was modified in the early 90s by Pennsylvania versus Kwaysee, and that decision was overturned last year in a ruling called Dobbs. And what Dobbs did is it sent the authority to say whether there is a right to an abortion back to the individual states. So we're now living in a sort of post-70s world again, in which the right to an abortion may be different in Maryland, may be different in Virginia, may be different in the District of Columbia, may be different in Texas. Dr. Hemphill, can you talk to us a little bit about what the pedagogy of midwifery and the practices were before that Dobbs decision and then after the Dobbs decision? Are there things that you used to do that you no longer do, things that you used to focus on or didn't focus on at all that you do? And then Michelle, I want to come to you as someone who is receiving that pedagogy and how the Dobbs decision affected you. Dr. Hemphill.
So I'm happy to say that living in the DMV, so DC, Maryland, Virginia area has not really changed much for us because it is legal as far as abortion rights are legal in Maryland, in which I practice, and then in which I teach as well. So my teaching is always, we still are for reproductive rights. We still will be speaking about preconception planning, pregnancy prevention, pregnancy planning. If someone has a positive pregnancy test, what does that mean for them? Putting it back onto the patient. What is it that you would like to do? Let's talk about your options. So the only difference would be for those who are in different states that has lots of restrictions. The legality of abortion varies from state to state. And as of March, so as of this year, about 13 states have put some sort of a ban or an abortion ban on there. And there's a lot of abortion, not a lot, but becoming, starting to become some abortion clinic deserts. So for example, North Dakota and I believe Wisconsin has no abortion clinics in it at all. So that's really important when you're teaching to other students who are, hopefully, or we will, when our midwifery program begins in fall of next year, they're going to be all throughout the US. And it's going to be important for me to understand that I need to have them looking to see what state they're in and what are the rules and regulations for their state, and then that's how you can be able to provide care or provide services to that patient who is asking for some information on where do they proceed from there. And then also viability. So I teach about viability being important. It's a difference between defining viability at personhood, which is when the egg and sperm meet, fertilization, versus all the way up to 24 weeks. That's going to be a difference when I'm teaching to let them know the impact of that and what that state is like. For example, in Georgia, if I have any students who is in Georgia, they're looking at personhood. They're also looking at 6 weeks. This is before a person even knows that they're pregnant. And so what are you saying to those patients that come into your office that sees you as that primary person to go to ask them, where do I go from here? And so my teaching before then was where it was just kind of like everybody has their, options and their opinions and what is it they want to do. And now it's kind of being more focused as to the state that person is living in and plans to kind of practice in. And then the last teaching thing I think of is trying to help my students understand that it's really not about them. This is not a pro-life, pro-choice decision. This is more about making sure you have your patients having some say about what they want to do for their body. So that being said, some patients may have different views than my students when they come out into practice can have. How do we navigate that? That is something else that I teach. What do you do with that when you have differing views? So, that the difference between before and after, not too much different, just a little bit.
No, I think that's wonderful. And that highlights a lot of the issues we want to get into in the Q&A, which we're about 15 minutes away from, folks. So if you want to start or putting your questions in the chat, you can DM myself or Victoria, or if you just are waiting and you're sitting on those questions, we look forward to having that conversation. Michelle, anything to add? And if you can emphasize, how is it different now as a student, as someone that's trying to become a doctor, and as someone that's practicing every day? How did Dobbs change both how you received the pedagogy and how that pedagogy was transferred into practice?
Sure. So I don't have too much to add. I will say that in terms of resource, the Center for Reproductive Rights has a great interactive map that's updated pretty regularly because things are just changing daily. And like, what was just explained, it might not be a total ban, but it could be a type of ban that is more, not as clear, that makes it difficult, whether just to get to a clinic or to actually receive the care or to receive the medications that we're seeing. Particularly in DC and Maryland, it's really hard to speak about because we have been, in terms of reproductive rights, have been very well protected, and certified nurse midwives have a pretty independent, strong scope of practice. And so people come and have come from all over the country to seek essentially abortion care in Maryland and DC. And I anticipate that this is just going to continue, if not increase, with a lot of these changes in other states. It means, though, that those of us who are tuning into the legislation and the changes that happen to DC and Maryland, we have to kind of be vigilant about changes that can be recommended. Again, it could be subtle changes, making it more difficult to access certain medications like misoprostol and mifepristone, which have been in the news. Could look like intervening with bans related to telehealth regulations. So we have to just watch, and I assume that, that even though we haven't felt immediate effects, there is going to be long-term effects from this. In terms of practice, I echo everything Dr. Hemphill said, that we are continuing shared decision-making, understanding what our own state laws are where they're at, because that's the best way we can discuss options and refer appropriately.
No, thank you for that. I think that's great information. And I shared the map that you shouted out from the Center for Reproductive Rights in the chat, if anyone wants to review that. Dr. Hemphill, going back to you, here at GSEHD, we specialize in teaching. And over the last year, it's been one hell of a year for anyone that teaches anything, right? Whether you're teaching African-American studies, history, social studies. Is there an approach you take to someone that says, look, Dr. Hemphill, personally, professionally, I don't believe in abortion, whether it's a religious stance or an actual stance. And because of that, I don't know if I can stay in this profession. You understand? How do you go about, guiding, mentoring, influencing that person to still be the best midwife he, she, or they can be, and have that conscientious objection that we all should have in America? And then, Michelle, I want to come to you. As you know, your classmates on the graduate level, but the School of Nursing has an undergraduate program. So, Michelle, I want to ask you about mentoring maybe undergraduates that are in the same boat. I personally don't believe in abortion, and I'm seeing some conflict between that belief and nursing. So we'll start with Dr. Hemphill, and then Michelle will go to you.
So as a professor, I will first applaud them for being honest and sharing their opinions and letting them know this is a non-judgmental way. They have discussion board posts where they're learning from each other and learning from their peers. And I'm going to be emphasizing the importance of people being able to express their opinions. I want faculty to be able to express their opinions as well. And we will be having case studies and dialogue on how to navigate through that. You are going to come across people, be it LGBTQ population, people of color, someone who has a history or current drug abuse, and how are we going to be able to do that? So having an opinion of pro-life or pro-choice is not different. You just put it under the umbrella of how can you put that patient at the forefront, put your feelings and your opinions to the back burner and still provide care. I would tell them that they need to lead with facts. They need to, one, listen. Sometimes when you have your own opinion and someone's coming in with something, you already feel like they're just completely against what you're saying. Maybe not. Maybe they're coming in feeling like that's the only option for them. But now you've taken the time to listen and realize, oh, they're asking about more options, or they're telling you why they feel like they need to have that. So I will be instructing my students to take a pause, to, one, first, really do a deep dive for themselves and understand where they stand in different types of things. Think about where they plan to work. There are certain environments where you will not have to do certain things, but to just be open and understand that you want to be a person that is going to provide care to everyone. They are coming to you for that help. It is hard. It is something that would need to be practiced all the time. It's a different way of having to view your life when you've been able to kind of sit in the way that you feel about certain things. And so we will have different case scenarios and different discussions to kind of, like I said, navigate on how to be able to handle patients that may have different views than you have and still love what you do and still love this profession and still feel like you are making an impact somewhere.
Well, that sounds wonderful. And it sounds like there may be a student at GSEHD that can come observe that and document it and publish the great work that you're doing over there in the pedagogy of nursing. These interdisciplinary connections is, I think, where we need to go. Michelle, do you have anything to add to that? And I really am interested, as a senior doctoral student, as someone that has been at GW for quite some time, if an undergrad came up to you and expressed the same thing, I'm thinking of transferring out, or I'm thinking of changing my major because I truly don't believe in abortion and I'm finding conflicts with my nurse practice or my midwifery practice, how would you go about guiding that young person?
Sure. I would say, in terms of if a student's going into midwifery, there's an expectation, and even nursing, that they should learn the tools to be able to hold space for diverse people with diverse choices that they may make. I mean, it's just part of our profession as a nurse and as a midwife. So I feel it's an expectation that they should be able to hold that space and kind of control how they respond. In terms of how they practice, though, like I've had midwifery students who don't believe in contraception and have been, felt really uncomfortable in the space in the clinical setting. And again, I mean, they've gone on, and we've discussed this, to work at a place that's going to be reflective of their ideals, usually like a religious institution. And there's a place for midwives who practice that way, and they're not going to be able to exist necessarily in a structure that is going to be, prescribing contraception, for instance. They're going to go to a place that, they'll be able to practice with what's comfortable for them. And I do think most of those places, I believe, are pretty upfront, those institutions, with what they can and will not do. So I do think there's no like underlining, like no one's being scammed in that situation. And I never want a midwife in any sense to do something that they're super uncomfortable with. That's when we see mistakes are made. That's when we see people not being taken care of appropriately. So I'd have those kind of conversations on where they see themselves. I think it's really important to talk through scenarios, because this is just one part of many different scenarios where I might, or someone might not agree with a decision that's being made. And that could also be in the birthing room. And we've discussed this a lot as midwives, that, this issue of reproductive rights, it extends into the birthing room. It extends to the, the decisions, hard and easy decisions that are made, and the things that are being done in the birthing room, and even, postpartum. So I think being honest, being able to have respectful conversations in the classroom setting, I mean, that's what higher education is for, right? To be able to have really difficult conversations in a respectful environment that, expands our capacity to be able to think and respond.
I chuckle a little bit when you said that's what higher education is for, only because I think that's obvious. But I think as a nation, we're losing that a little bit.
Of course.
And I think that's so dangerous. So Michelle, let me just do a quick follow-up. Many of our conservative friends say that the problem is conservative students are ostracized, if not formally, socially, that when they express their views, they're over there almost segregated, as we used to segregate black and white in the day. Has that been your experience? What's the truth there, right? Because there's what the media decides to show us. What's the everyday practice? Do you have students, friends that you went to school with, both in the public health school and the nursing school, that are conservative? And are they ostracized from either professional or social events?
I mean, I have had students that fit that, and ostracized. I mean, that can be intense, but I definitely can see how they could feel really uncomfortable. I can understand how they are devalued in some way from other teachers, because feelings are so strong. I think they've ended up becoming wonderful practitioners in servicing humans that have shared ideology. Again, I have not seen them go into the world and kind of have jobs where you feel like they're manipulating clients, or, there's some weird subversive things that are out there. I don't see that. But I think that's important of good mentorship, is having those discussions. But I've definitely seen that, and it's unfortunate.
All right, so folks, it is 3 o'clock. I've got one more question, and then we're going to turn off the video. We're going to go to your Q&A. I had about 50 other questions planned, but maybe I could get them into the Q&A, with apologies to the folks that are joining us on the recording. But before I go to my last question, Dr. Hemphill, anything to add on the last points we were making about, maybe conservative or Christian students being ostracized? I know for a fact it's not happening in your classroom, so I won't even ask that question. But on this, the field in general, what's the mood going on in nurse classrooms?
I mean, I definitely can see that happening. And, like I said, that's why I try to take a pause and just applaud them. Sometimes it just takes guts to even be able to, you see everybody is saying go to the left or to the right, and yet your views are different. And so being able to voice that. So I do believe that. I do feel like a lot of times people feel like everyone should be thinking the same and everybody should be on the same page, but that is not what the world is. So we do need diversity, not just in the race, but in people's thoughts and views. And so I just try to encourage, acknowledge that, yes, I do believe that what you're feeling is absolutely true. And that is what's happening. How do we move from here? How do we make your voice heard? Because your voice is important as well, because there are patients who would be so happy to receive care from you because you both feel the same way. They don't have to keep explaining why they feel XYZ way about contraception. Please stop asking me if that's something that I want. I do not want that. And once, you already have issues with access to care, but sometimes it's not just an access to care, it's a relationship development with their provider. Right. And some people come in and they don't get a good connection with their provider, and therefore they do not go back and seek care. And then they start to think that all providers are like that. So there's a place for people with varied views on life, and just being able to have that connection and have someone there who has that, let's say, conservative view, and have a patient who matches that. And it's just a match made in heaven. They will continue to receive care. So I think it's important. So I would encourage them to continue with their views. No, they don't have to change who they are.
That's wonderful to hear, and as DEI as an acronym is under attack in America, I often remind our colleagues, DEI is about conservative views too. Mm-hmm. Right, we're all, diverse, right? Mm-hmm. There are conservative Black women, there are liberal Black women. There are mm-hmm. conservative white women, there are liberal white women. There are conservative LGBT folks. So I think that the fact that this is becoming bifurcated, I think we're losing how actual people operate in their lives. Mm-hmm. It's about intersectionality, not division. Last question before I throw it over to our audience, and please do prepare for your questions. So at the end of this answer, Victoria, we'll stop the recording, and there are a few of us, so we'll go into one room so we can see each other, but please have your questions ready. Here's the question, queen for a day, right? So both of you, and we'll start with you, Michelle, and then we'll go to you, Dr. Hemphill. Doesn't have to be about abortion rights, doesn't have to be about midwifery, but there was one public health policy that if I gave you a magic wand, and if it were improved on that magic wand, you said would vastly improve the lives of women and girls in America, what would it be? And I'm going to repeat it again because I want to give you a little bit of chance to think about it. I'm going to limit you to just one. The genie comes out, and instead of three, you get the one wish, and you can modify a public health policy or enact a public health policy that if that actually goes through without any contention, it would greatly improve the lives of women and girls in America today. What would be that health policy modification or implication? Michelle, first to you, then to you, Dr. Hemphill.
I would say passage of legislation that supported independent practice for midwives in every state. Essentially a midwife for any person that wants it. And we would see, and this is all backed on by evidence, we would see improvement in maternal health care. We would see improvement for birthing women, birthing people and their babies. It would be immediate, it would be cost effective, it would have long-term positive consequences on not just the birthing person and their child, but the community. And I think, of all the other things, non-clinical, we'd start to see sovereignty, sacred, respect for pregnancy in the perinatal period, respect for sovereignty, investment in families, which we all know has long-term consequences. So I'd say independent practice for midwives in all states, and a midwife for any person that wants it. That wants one.
Thank you to future Dr. Clausen. For the current Dr. Hemphill, what would be your choice?
So I really like the Midwives for Moms Act. It's the Midwives for Maximizing Optimal Maternity Services. And it does three things. So one, there's a lack of diversity in healthcare. Studies have shown that is a fact, unfortunately. And so this is one way of trying to increase the diversity within the healthcare field by bringing more students into midwifery programs, let's just say. And then also just trying to increase the workforce. And so we are having low numbers with that. And so that helps encourage us to be able to get more students for that. And they also offer grants to universities and colleges to bring in more people of color, more BIPOC students, to bring them into schools by kind of removing that barrier of finance. And so, you know, it's about, for right now, there's about 85% of white women who are midwives, 7% are African-American. So I really feel like this is a strong need to try to get more people of color into the midwifery program and into the life of midwifery. There's been people who would say, I feel more comfortable being cared for by somebody who looks like me. I feel like my voice is being heard. I want to continue to seek care with them. There's something to be said about that. You know, we need to get more role models out there that see, like I see someone who's doing this profession, I want to do that as well. So this Midwives for Moms Act kind of helps with that. And, you know, Michelle had mentioned before that the US is different than international. So these low numbers of midwives of color, I think is a correlation to these high numbers of maternal mortality rates. You know, if you compare us to other countries that's really midwifery driven, their mortality rates are a lot lower than ours. So this act, by bringing in more people, educating them, and then putting them out into the world, I think will really be beneficial.
Brilliant is the only word that can describe those answers and this entire question. We're going to say goodbye to our audience that will be viewing this at another time, and we're now going to move to an audience Q&A.